gonna talk with my experience. So what Bansi Bhai asked me to do, he said, you have stayed 12 years in UK, you have stayed 12 years in India. You have practiced 12 years in both sides. Now you tell me your story and what are the small points that you have learned in the process. So this is more predominantly what my journey is, and maybe some subtle changes which I have found that has shaped who I am today. So that is what I made my presentation on. It's not hardcore science, a lot of hardcore science is happening. This is more a soft presentation, which is my perspective, which may not be the correct perspective. So that's a disclaimer I have before I start. See, I belong to a very small town. I belong to a city called Guwahati in Northeast. I don't know how many people have gone to Northeast and how many states people know there are in. There are very few people who have gone there. And I have done my whole education there and never gone out of Assam only. So after when I had done my MBBS, I failed in surgical branch in the final MBBS, and I got very distraught. My father got distraught, he's an MD medicine. So I decided I will not do PG there, also because of the reason I was not a very intelligent boy. I didn't know I'll get into PGI SIRS or AIMS or somewhere, all India criteria मिलने वाला ही नहीं था. और हमारे यहाँ 3-3 साल में PG का एग्ज़ाम होता था, तो वो तो होना ही नहीं था, और सगाई भी हो गई थी, खर्चा भी कैसे करेगा यहाँ बताइए, बीवी का भी प्रेशर होता है. So I decided I'll go to UK. But why I went to UK was, I saw 2 of my seniors had gone to UK. So lesson number 1 is the perspective what your peers bring to you is how you move. Because मेरे यहाँ से US कोई जाता ही नहीं था. उस समय ये था MLE का तो वीज़ा मिलेगा ही नहीं, क्यों मेहनत कर रहे हो, बर्बाद हो जाओगे, ऐसा हो जाओगे, वैसा हो जाओगे. तो ऐसी एवरेज स्टूडेंट, ऐसी पढ़ाई का मन नहीं, तो उतना एफर्ट तो जाना ही नहीं है. तो जब मेरा एक सीनियर गया तो कहता वो भी एवरेज था, मैं भी एवरेज था, चलो चलेंगे गाड़ी. So that is how the journey to went to UK happened. You have to give an exam called PLAB, which I had done. And when I was doing my internship, I got engaged, and my whole internship of 1 year MBBS was more about cannulas and catheters, and also getting free certification by MS. जिसके पास पैसे नहीं थे, एक लाल फॉर्म था, सर पैसे नहीं है इसका, फ्री करा दो सारा टेस्ट. ये इंटर्नशिप हमारी 1 साल की थी. 2 महीने का मेरा रूरल सर्विस था, जहाँ पे मैं जब गया तो उन्होंने मुझे बोला आ क्यों रहे हो भैया, मत आओ, लास्ट टाइम आ जाना, एक गिफ्ट लेके आ जाना, हम साइन कर देंगे. So that was my rural experience of 1 month. I'm telling you the honest truth. I'm not here to fabricate. जो सच है जो सच है. तो और जहाँ तक MBBS पढ़े थे तो वहाँ तो एग्ज़ाम में हमें मर्सिडीज बेंज साइन और ये सब पूछा जाता था, रेयर कॉजेस. कॉमन कॉजेस तो पूछते कहाँ हैं, बिकॉज डिस्क्रिमिनेशन कैसे होगा अच्छा स्टूडेंट और एवरेज एंड इंटेलिजेंट स्टूडेंट में. ही शुड नो मोर. So this was a different perspective, because I remember my sister got into dentistry and there was you had to go for something and somebody fainted. तब तक मैं second year, third year student था, and somebody fainted. They said कोई medical student है क्या, somebody has fainted. I could not put my hand out because I didn't know what to do. I knew Mercedes-Benz signs, but I didn't know what to do if a person has fainted. And so that was a system which I felt at that time, and things have now evolved. It's a lot of theoretical basis. You learn more in the PG, you learn as you are doing internship, but I didn't know what to do and I didn't put my hand up, and I was very embarrassed. Luckily that person didn't die, but he was a diabetic patient whose sugar had fallen low, later I knew. But that is not what it's imbibed in you, the ABC, how to approach. So 30th November I landed up in UK, 2002, very cold, 30,000 rupees money in my pocket, no more money. It was very difficult. Eventually you had to get a clinical observership there. So once you do PLAB, there is an exam to go to UK which is called PLAB, which has got a theoretical basis and a practical basis. And once you do that, you have to become an observer, a clinical observer. अब clinical observer में कुछ नहीं है, you have to move around like a junior doctor, impress, and if there is a door open, you get as a locum and then you get a regular job. That is how the system works in UK, called PLAB exams. When I was a clinical observer, basically you are trying very hard to motivate, to tell the make an impression upon your boss. लेकिन पॉकेट में पैसा नहीं, खर्चा उधर निकल रहा है, एक CV और एक स्टैम्प पेपर भी 30 pence का आता था. So it was very difficult to go through that circumstances with less money in your pocket. Eventually your food used to come down, your weight used to come down, because the application had to go for jobs. And you didn't know how to write a CV. I didn't know what to write a CV because I've never written a CV. I didn't know what curriculum vitae means at that time of time. Small town boy, not a Delhi, Bombay, Ahmedabad boy. Very small town I belong to. So I went to my clinical observer, he was a Sri Lankan. I asked his CV mein kya likhna hai? So I wrote, my father is a doctor, blah, blah, blah. He said, I don't care who your father is, even the prime minister. He told me these words. Tell me what you know, even if you don't little, just write very little. That I did my internship. That's all it matters. So it really doesn't matter what your background is. It matters what you want to know. And the most important thing that she taught me there is that what I want my junior to know is to say, I don't know. That is the biggest lesson I learned in the UK, to say, I don't know. Ask for help to your senior. Can you imagine doing that? I don't know, यहाँ पे मर जाएंगे भाई, वो PG पास ही नहीं होता. अगर बॉस को बोले आई डोंट नो, बोला किया तुमने 3 साल से, आई डोंट नो बोल रहा है. सो देयर इज अ डिफरेंट पर्सपेक्टिव दैट इज देयर. सो दैट इज द पर्सपेक्टिव आई वाज टॉक टू say. And then when you, because we are all used to talking teachers sir, the first time I talked, there was a boss I had called John Mills. I said, Dr. Mills, sir, what can I do for you, what can I bring for you? He said, I am not knighted. He says, sir means only when you are knighted. It becomes very difficult. I have come from a background जहाँ sir के बगैर तो आपका statement ही नहीं start होता, हिम्मत ही नहीं होती. You can call first name or surname of your teacher, but out of respect. This is what our culture is. But there it is very difficult. He wants you to call by his first name, and if possible second name if you still want to do. Then when I came back to India, imagine how much I have to retrain my mind. उधर फर्स्ट नेम सेकेंड नेम, इधर सर निकल ही नहीं रहा है, बहुत मुश्किल से निकालना पड़ता है. सो दैट चेंज हैज़ बीन, यू नो, ईस्ट टू वेस्ट टू ईस्ट हैज़ बीन really difficult for me. That has to be there. In the UK the system is, sir please remind me, I can keep talking, there's not much, it's all stories here. In UK you become a senior house officer, you become a registrar for 5 years, and then you become a endocrinological consultant. This is secondary care, which is based in the hospital. The primary care, you become a GP, and then you can become a GP with a special interest in diabetes, in endocrinology, in gastroenterology, whatever you want. So special interest means 5 दिन काम करने का होता है, 2 दिन वो specialist का काम करेगा. And that means he'll run a specialist clinic in his GP surgery. So what is GP surgery? General practice, that's called GP surgery, is area of 5,000 patients are registered to me. I will decide what I need to do for this patient. I have to discuss this patient in 7 to 10 minutes, including calling him from the waiting room, asking him to go out, writing in the computer, and making sure there is no complaint against me, because settling the complaint takes more time. So 7 से 10 minutes you were taught how to write, how to take a consultation, to finish the consultation. This is general, not just related to diabetes. And if you want to become a special interest, you can do a diabetes clinic once a week, because the money is in primary care. If anybody wants to go to UK to make money, money is more in primary care, GP part, not in secondary care. Secondary care is a salaried job by the hospital. Primary care is a business. The hospital, the government gives you per person, you can have your own pharmacy, and you get points by QOF, QOF, quality outcome. QOF में क्या होता है? You have targets. 70% of my patients have HbA1c less than 8%, you will get so many points. Each point is equal to so much rupiah. 90% of my patients have HbA1c less than 7%, more points. 90% of my patients have blood pressure less than 130, more points. So more points is equal to money. So the whole service oriented that happens in primary care population is predominantly money generated loan, which also is good. You know, then CGMS doesn't go out of the window, HbA1c नीचे लाना है, because उसको पैसा HbA1c से ही मिलेगा, उसको पैसा blood pressure से ही मिलेगा, क्या होता है उससे मिलता है, and they are referred to the hospital that is there. One thing which I learned in my ward rounds by my boss at that time was that if I wrote a word called CST, everybody know what is CST? I would be punished if I write CST, because CST means nothing. What is your plan is important. My plan is I will discharge this patient after 24 hours provided A, B, C happens. CST means कुछ नहीं आया, घूमा, CST लिखा, साइन मारा, आगे चला गया. Because it is a social driven healthcare system, they need the bed. In India, which is more private care, the bed, more the person stays in the bed, the better is for the hospital. But the hospital makes the money in the first 48 hours. Uske baad that person is a liability. You need to move, get a new patient in. Public service is different, I have not worked, but still the rapid CST word was not, we are not allowed to write, we have to write the plan. The plan may be right, the plan may be wrong. That is your training. The boss will come in the round and tell you whether your plan was right or wrong and correct. But you have to write a plan. You have to commit yourself that this is what I want to do from my patient, and that was the biggest learning I learned when I did there. Covered that. Diabetes is run predominantly by nurses. I learned a lot of my diabetes from nurse. I learned a lot of my diabetes from a metabolic physician. I still owe him a lot because he allowed me to experiment everything in his lab, which was, you know, maybe he liked me, maybe he didn't like me, whatever the reason was. And from the nurse, I learned a lot of diabetes. So I personally do not believe, or I was taught not to believe, if you write come back in 6 months, it means useless. There is no point in diabetes care come after 6 months. You have to give a plan. ऐसा नहीं हो, ऐसा हो, ऐसा हो, तो आप आ जाना. नहीं तो भाई अगर ठीक नहीं हो तो फिर 6 महीना वेट मत करो, 1 महीना में ही आ जाना, 3 weeks में ही आ जाना. So that kind of communication was there. One important thing I was taught when you talk to your patient is KYC. KYC in diabetes is what I was taught there. All banks do KYC. We were taught to do KYC, know your customer. Because 7 minutes में उसको बाहर करने का. If you cannot understand what your customer wants, then too you are in that vicious cycle of finishing and catching up and going home late and writing complaint reports. So you have to quickly find out what your customer wants and what doesn't your customer wants. And there used to be a 360-degree feedback which was taken by everybody, from your juniors, from your seniors, which was anonymous. And that is how your bonuses were given. If you are not performing well or performing well, your juniors' value was taken more. Because senior के साथ तो आदमी सब अच्छे से रखता है, junior के साथ अच्छे से नहीं रहता. So that feedback from the juniors was very, very important. But saying all that, UK system is a conveyor belt. अगर आप यहाँ जाओगे तो धीरे धीरे उधर पहुँच जाओगे. There's so many red tapes. You know what? You cannot change the red tape. It's very difficult. गोरा तो red tape कर ही नहीं सकता. कोई गोरा है नहीं तो we can say, I can say this. I can say that on their face also. And what I learned also after living for many years in India, गोरे ने हम पर इतना राज किया, आज भी हम गोरे चमड़ी को सुपीरियर मानते हैं. वो सारा डाइल्यूट हो गया. बिकॉज ही गोरा जो स्पेशलिस्ट हम क्लिनिक्स बोलते हैं, जो करते हैं, वो पेशेंट देखता ही कितना है वो स्पेशलिस्ट क्लिनिक से. यू विल बी सरप्राइज्ड. महीने वो सप्ताह में 2, 4, 5 पेशेंट खाली वही देख रहा है. वो 2 पेशेंट, 2 पेशेंट, 4 पेशेंट, 5 पेशेंट. बंसाली सर तो वही स्पेशलिटी का हजारों पेशेंट देख लेंगे भाई. So that perspective that Gora is superior quickly diluted away from my mind, that the brown skin is not inferior. In fact, we are far more superior in our thought process than the white skin in how we actually approach the whole game. The only problem is they have a more structured approach. Ours is not a structured approach, but because we have also more population, we have to deal with a lot more other things, and they have to deal with. In a standard clinic, I had to see 10 patients, 8 to 10 patients. अगर गोरा 10 देख लेता था उसके तो पसीने आने लग जाते थे 3 घंटे में 10. अब यहाँ 3.5 घंटे में आप 10 देख लोगे तो घर ही नहीं चलेगा. So it will be very difficult. So those are different. That's why more things were said. And I don't think there will be a Bansi Sabu also in UK. It's not possible. The amount of innovation he can do here, because he can bring new changes, fresh changes. Red tapes are very much there. But I remember at that time we had Bhartia, the GLP-1 analog, and I had 2 Goras, 2 bosses. One was a Gora, one was a Desi, and they had a strict cutoff. BMI more than 30 only you can give GLP-1. So the patient's BMI was 29.5. तो अभी दे या नहीं दे, तो मैं गोरी के पास गया. वो बोला अरे 29.5. No. You call the patient after 6 months. I went to a Desi consultant. You said you make him wear the overcoat. अगर 30 नहीं होता है तो उसको पायोग्लिटाजोन दे दो, 1 महीने के बाद बुला लो, BMI 30 हो जाएगा. So that thought process does not exist in Goras. That, you know, they go by strictest of the words. That fine tuning doesn't exist with, you know, that practicality of the world does not exist with them. And that is a subtle difference if you think, if you feel that's a very important difference, because there's no point subjecting that patient. A lie is an omission or a commission, you can decide what is more beneficial for your patient. When I came back in India, I found that there is a 30-day rule. I want to find out, all senior clinicians are there. ये केस डॉक्टर ने बनाया है, 30 दिन तक हम पैसा वापस नहीं लेंगे पेशेंट से. Because patient comes and says, सर 1 महीना तो हुआ नहीं. I'm sure everybody feels this. लेकिन वो 1 महीने का रूल बनाया है किसने? So the reason being, we have blurred our margins of personal and professional life in India. We take more pride in saying we have sacrificed our personal life for the sake of the patients. अरे मैं खाना नहीं खाया, अरे क्यों नहीं खाया भाई? खाओ, अपना हेल्थ का तो ख्याल रखो, थोड़े ना कोई पेशेंट आने वाला आपके पास. I have seen 50 patients, 70 patients, 80 patients. Why are you seeing? Who's forcing you to see? Is it seeing 80 patients better or seeing 25 patients better, quality patients better, is a matter of perspective. You know, what is better, what is more qualitative, is depends if you've seen 100 patients in a day or not, is very important. There's another default status that exists. In India, what I felt, the default status is that you are lying. बॉस मैं आज नहीं सकता, तबीयत खराब है, अरे रात को मैच था ना, इंडिया पाकिस्तान, देरी से मस्ती किया होगा. In UK, the default status is truth. If you are saying you are unwell, I am unwell. End of story. There is no argument. I can't come, I can't come. You cannot ask the second question, why you can't come. I have said I cannot come. अगर गलती होगी, if I have said sorry, now if the boss says second time, punishes me, I can take him, his job is gone. Because I have said sorry. I have already surrendered. उसके बाद क्यों डांट रहे हो मेरे को? कहानी खत्म वहाँ पे. So that is a matter of perspective. The waiting list is a problem in diabetes in UK. Because if you look at a chronic condition, see, it's managed by the GP. If they have a problem, it goes to the hospital. There's a long waiting list. So I think the quality of care in a chronic condition like diabetes is far better if you have if you're running a specialized diabetes clinic in India. Much, much better. The only difference is that that is fully paid. So when I came back, I used to write all the tests, urine ACR, because I have learned that way. Patient बोलता था ऐसा होता नहीं है, फिर उसको मैं installment में करने लग गया. So that is a perspective. I learned fasting PP management only when I came in India. I wrote glimepiride only when I came in India, because it was not written there. I had never written premix insulin for 12 years in my life. I still find it very difficult to write, because what your bosses teach you is always right. आपने जो देखा है वही सही है. I'm not saying what is right, which insulin is right or wrong, but it becomes very difficult. I've always written gliclazide. Writing glimepiride was very difficult for me. ये क्या molecule आ गया कहाँ से? वहाँ तो वोग्लिबोस आप बोल दो तो ऐसा पसीना निकल जाता था, बोला ये तो बेकार का molecule है. यहाँ वोग्लिबोस अकारबोस बहुत चलता है और काम करता है. So it's a perspective difference that is there. I'll finish off, sir. I think data collection post marketing in India, it happens very, very easily, because I saw that in my internship days, and that is why the quality is not well respected outside. I think that is where some refinement can happen. I think I would like a UK system in which a Bansi Sabu can also be created and bring changes. I think that would be a big change that would be there. But I think what I learned from both things is that you can get affected. You decide your parameters and your ethics, what you can be diluted, what cannot be diluted, but do not ignore your family, because they are the only ones that will count. The rest will come and rest will go. With that, I thank you very much for your patient hearing. Thank you so much.